Welcome to the NORCAL Mutual Webinar, Process Improvement, 3 Key Areas for Success. I am Shirley Armenta, Senior Program Lead with NORCAL, and I will be your moderator today. Before I introduce our speaker, I have a couple of items to review. The information contained in this presentation is intended as risk management advice. It does not constitute a legal opinion, nor is it a substitute for legal advice. Legal inquiries about topics discussed during this presentation should be directed to an attorney. Faculty and planners for today's program have no relevant financial relationships to disclose. Our speaker, Kelly Rinehart, is a Senior Risk Management Specialist for NORCAL Group. She began her career as an operating room nurse and now has over 20 years experience in healthcare risk management. Kelly assists policyholders through phone consultation, presentations, resource development, and on-site practice assessments. She's also a Master Team Steps trainer and has conducted numerous Team Steps trainings for hospitals and clinics. And now I'm going to hand off the presentation to Kelly.
Thank you, Shirley. Let me get my slides up here for you. There we go. Okay. Welcome everyone to today's webinar on 3 strategies for process improvement. Let's take a look at our objectives for the presentation. First, you want to learn how to develop and implement checklists to mitigate professional liability risk and enhance patient safety. You also want to identify and overcome communication challenges through the use of effective communication techniques, and integrate a variety of team strategies to enhance your care team communication. You also want to apply the steps of providing a meaningful, informed consent discussion. Let's first see how many of you already are using checklists for patient safety. If you'll take a moment to answer the question, we'd appreciate it. Does your practice use a timeout checklist prior to a procedure?
As you can see, Kelly, I have launched the poll, and so we are waiting for results to come in. I'm going to give everyone a chance to select their options there, and it takes a little bit sometimes for the transmission to come through. So, all right, I'm going to go ahead now, and I'm going to close the poll, and here are the results.
Okay, we have 33% of you who are saying, yes, you do use a checklist. Congratulations, that's great. 20% of you are not, and 47% say it depends upon the procedure. Well, those of you who aren't using a checklist, we're going to give some good tips in the presentation today, so you might want to try developing one and implementing one for procedures that you do in your practice. Here are some statistics that may make you want to consider developing safety checklists in your practice. Each year, medical errors lead to death for as many as 180,000 to 400,000 patients, making medical errors the 3rd leading cause of death in the United States. The 9th edition of the World Health Organization's International Classification of Diseases has grown to more than 13,000 different diseases, syndromes, and types of injury. And for nearly all of them, there are treatments to help. However, for each condition, the steps are different and they're almost never simple. Clinicians now have at their disposal some 6,000 drugs and 4,000 medical and surgical procedures, each with different requirements, risks, and considerations. It's a lot to get right. It's been said that while medicine used to be inefficient, simple, and safe, it is now effective, highly complex, and dangerous. Realizing how prone we as humans are for short-term memory loss, it's striking how many potentially dangerous medical procedures are based on perfect memory. Although a seemingly simple intervention, checklists have a sound theoretical basis in principles of human factors engineering, and it played a major role in some of the most significant successes achieved in the patient safety movement. The field of cognitive psychology classifies most tasks as involving either schematic behavior, those are tasks that are performed reflexively or on autopilot, or attentional behavior, which requires active planning and problem solving. The types of errors associated with each behavior are also different. Failures of schematic behavior are called slips and occur due to lapses in concentration, distractions, or fatigue, whereas failures of attentional behavior are termed mistakes and often are caused by lack of experience or insufficient training. In healthcare, as in other industries, most errors are caused by slips rather than mistakes, and checklists represent a simple, elegant method to reduce the risk of slips. Flight preparation in aviation is a well-known example, as pilots and air traffic controllers follow pre-takeoff checklists regardless of how many times they've carried out the tasks involved. By standardizing the list of steps to be followed and formalizing the expectation that every step will be followed for every patient, checklists have the potential to greatly reduce errors due to slips. The checklist is a structured process in that it creates a framework for discussing plans, addressing concerns, and confirming critical information at key points in surgical workflow. It's also performed as a team. It encourages people to move out of their individual work silos by asking everyone to pause and discuss information together as a team. It's also a trigger for discussing critical safety steps. Short prompts help ensure that the surgical team discusses and performs those safety steps that are most likely to be missed and have the most potential to affect patient outcomes. A well-designed and properly used surgical safety checklist delivers these key safety benefits. It helps us do what we know needs to be done for every patient every time. And it ensures that we have the necessary information to take excellent care of the patient. It also gives every member on the care team a voice. And it builds stronger and safer teams. And it also makes patients feel safe and involved in their care. I think we're all familiar with some of the more publicized checklists, such as the one used in the Keystone ICU project for eliminating central line infections, and of course the timeout checklist. However, upon doing some research on other checklist uses, I found all the checklists you see on this slide. It's easy to build a checklist for non-clinical activities that are not dependent upon evidence-based practices, such as the ICU central line and timeout checklists. As you can see from this list, checklists are not just for the hospital setting. You could develop a new patient checklist or an exam room supply checklist so that you can restock exam rooms quickly and efficiently. The Institute for Safety in Office-Based Surgery has developed a template for a safety checklist to be used in an office where procedures are being performed based on the work of the World Health Organization. This template can be customized to meet the needs of the specific subspecialty and office setting. I've listed the link on the resources slide at the end of this presentation. If you decide that you want to use this checklist, I would highly recommend you and your team taking a careful look at it and make some revisions to customize it to your practice. No checklist is a one-size-fits-all. In addition, you want your team to have input into the checklist so they have ownership of it and will use it. The Institute for Safety in Office-Based Surgery is currently collaborating with various proceduralists and surgeons to help them customize the safety checklist to reflect their specific practices. There will be specialty customized checklists for dermatology, pain management, plastic surgery, and more. So I would encourage you to keep an eye out on this particular website for other checklists that may be available to you. Safety tools designed to support team communication are most effective when they're applied through an interdisciplinary approach within a culture of safety where every team member feels equally engaged to speak up to support patient safety. Applying evidence-based approaches to improve communication by incorporating team training, simulation training, standardized transfer of patient information, briefings, timeouts, surgical safety checklists, and debriefings can support the team members in preventing the staggering number of preventable adverse events that harm patients. Now I'd like to introduce you to a communication and teamwork training method called Team Steps. I think you'll see how applying communication and teamwork principles is critical for implementing meaningful checklists that truly prevent patient injuries from occurring. Let's assess what teamwork strategies you're already using in your practice. So if you'll take a moment to answer this question, we'd appreciate it. What teamwork strategies are you currently using in your practice?
All right, Kelly, you can see again that I have launched this poll. So results are just starting to trickle in, and we'll let everyone have a chance to make their choices there. And I'm going to go ahead and I'm going to close this poll, and here are the results.
Well, this is wonderful. I'm very impressed with all of you. 33% of you are doing huddles. 67% are doing briefings. That's fantastic. 0% are doing debriefings, and 11% are doing none of the above. So we're going to talk a little bit about debriefings, and I hope that all of you will see the value in doing a debrief and will incorporate that into your communication strategies. Based on research, we know that teamwork is defined by a set of interrelated knowledge, skills, and attitudes that facilitate coordinated adaptive performance in support of one's teammates, objectives, and the mission. Effective teamwork depends on each team member being able to anticipate the needs of others, to adjust to each other's actions and to the changing environment, and to have a shared understanding of how a procedure should happen in order to identify when errors occur and how to correct for those errors. These are the 5 key components of the Team Steps methodology. However, we're just going to cover the communication and leadership components in this presentation. We all know how important communication is in healthcare. Communication must always be accurate, clear, and acknowledged. Let's take a moment to watch a video on communication, and you determine for yourselves whether communication was successful.
Dr. Weiss.
Bill, hi, how are you?
I'm fine, Susan, and you?
I'm well, thanks. How's Maria?
Maria's great. She said to say hi.
Oh, she's so sweet. Tell her I said hello. So, why are you here?
Oh, I've had a bit of a problem, and I was hoping you could help.
Okay, what's up?
I did something to my back playing golf. It's just killing me.
We're pretty busy today. Did you try to schedule an appointment?
That's the problem. I have an appointment scheduled for tomorrow afternoon, but I'm leaving the country tomorrow morning on business. It just slipped my mind. It's just killing me.
Say no more. We'll get you taken care of. Stephanie, can you start an intake sheet for Mr. Olson, please?
Of course, Dr. Weiss. Okay, here we are.
Thanks, Stephanie. I'll make sure to tell Ryan that Mr. Olson's in room 3 so we can go ahead and start his intake.
Okay.
Come along, Bill. Here we are. You can wait in here. Someone will be along with you shortly.
Thanks again for squeezing me in.
Sure thing. See you in a bit.
Excuse me. Sorry to interrupt. Do either of you know about patient Bill Olson in 3?
No. Who?
Bill Olson in exam room 3.
Oh, no, I have no idea.
No, huh? Any ideas of what should be done with Mr. Olson then?
I don't know. Maybe get his vitals?
Dr. Weiss, do you know anything about patient Bill Olson in exam room 3?
Oh, yeah. Sorry, Ryan. It's been a busy morning. I put Bill in exam room 3. Did you get his vitals yet?
No, I haven't. I was trying to figure out the situation with Mr. Olson, but no one seemed to know anything, so I didn't start yet.
Okay, let's get on that. Bill's appointment was originally scheduled for tomorrow, but he needs to be seen today, so we're squeezing him in right away. Get his vitals as soon as possible.
All right, then.
Thank you.
Stephanie, what's going on with patient Olson in exam room 3?
His name is Bill.
I know his name. Why would you put him there without telling me?
I'm sorry, Ryan. Mr. Olson knows Dr. Weiss. He approached her directly. She said she'd let you know about it.
Fine, but I'm the MA. You have to communicate these things to me.
I know. I'm sorry. But I was completely bypassed. I just handed off the intake paperwork. I figured Dr. Weiss would take the reins and let you know, since it was her deal.
So was the communication in this scenario effective? Let's discuss some of the communication issues. First, there was a lack of communication about the unscheduled patient put in an exam room, and that was frustrating and confusing for the medical assistant. And then trying to track down information led to further delays in the schedule. And the MA just popped his head in the door of the exam room, but did not address the patient. It also appeared that the receptionist's role was to inform the back office staff of any changes, how to tell the MA about the patient. This lack of communication really did not demonstrate effective teamwork, and it led to frustration for everyone. Communication is the lifeline of a well-functioning team and serves as the foundation for all other teamwork strategies and skills. And believe it or not, good communication skills can be learned. It requires consistently modeling good communication skills and setting expectations. Communication tools can be very helpful to not only learn good communication skills, but to also ensure communication has occurred. Here are some examples of standardized communication techniques that you may or may not have heard of. The first one is SBAR, and that stands for Status, Background, Assessment, and Recommendation. This is a very common communication technique used in hospitals, and it's very effective, and physicians also like it because only the facts are stated. I call it bullet-pointed communication. I even know a nurse who taught her teenagers to use SBAR when they talk with her about a problem they're having. The next one is a call out, and that's a strategy used to communicate important or critical information. It informs all team members simultaneously during emergency situations, and it helps team members anticipate next steps. The next is the check back, and that is a closed loop form of communication. A sender initiates a message, a receiver accepts the message, provides feedback confirmation, and then the sender verifies the message was received. Lastly is the handoff, and that's the transfer of information during transitions in care across the continuum. And it includes an opportunity to ask questions, clarify, and confirm. Standardizing communication methods in your practice will ensure that information is communicated in the same fashion by everyone. And this will enhance accuracy of information as well as set expectations for communication within the practice. Now let's watch a video demonstrating good communication.
Dr. Weiss?
Bill, hi, how are you?
I'm fine, Susan, and you?
I'm well, thanks. How's Maria?
Maria's great. She said to say hi.
Oh, she's so sweet. Tell her I said hello. So, why are you here?
Oh, I've had a bit of a problem, and I was hoping you could help.
Okay, what's up?
I did something to my back playing golf. It's just killing me.
We're pretty busy today. Did you try to schedule an appointment?
That's the problem. I have an appointment scheduled for tomorrow afternoon, but I'm leaving the country tomorrow morning on business. It just slipped my mind. It's just killing me.
Say no more. We'll get you taken care of. Stephanie, can you start an intake sheet for Mr. Olson, please?
Of course, Dr. Weiss. Okay, here we are.
Thanks, Stephanie. I'll make sure to tell Ryan that Mr. Olson's in room 3 so he can go ahead and start his intake.
Okay.
Come along, Bill. Here we are. You can wait in here. Someone will be along with you shortly.
Thanks again for squeezing me in.
Sure thing. See you in a bit.
Hi, Mr. Olson. Just checking in to make sure you're comfortable. Is everything all right in here?
Yes, fine. My back's killing me. Otherwise, I'm fine.
Okay. I see here you have a herniated disc. Does it feel like your lower back? Is the pain familiar?
Yeah, it's my lower back, and it's all too familiar.
All right. Well, we're a little backed up with patients today, but just hang tight, Mr. Olson, and someone will be with you as soon as possible.
Great, thanks.
Excuse me, doctors, but I have a patient, Olson, in exam room 3, who isn't on the schedule today, and I'm not sure how we got there. He's complaining of severe low back pain and has a history of back problems. And most recently, he was diagnosed with a herniated disc. It seems logical that the disc is giving him pain. I think someone should see him as soon as possible because we're stacking up patients in the waiting room. Anybody know anything about this or want to jump on it?
I'm sorry, Ryan. I'm not sure whose patient he is.
He's not mine.
All right. Thanks anyways.
Thank you.
Hey, Stephanie.
Hey, Ryan, what's up?
I have a patient, Bill Olson, in 3, and he's not scheduled for today, so I'm just trying to assess on what exactly is going on with him.
Oh, yeah, Bill Olson. He's a friend of Dr. Weiss or something. He caught her attention and approached her directly. She had me start his intake paperwork, and she took him to 3. She said she'd tell you.
So to make sure we're talking about the same patient, he's William Olson, patient of Dr. Weiss, correct?
Yes.
All right, thanks.
Yep. And he has a history of low back pain.
Herniated disc, yeah. I have his paperwork right here. I was just trying to figure out what was up. I'm gonna hurry up and get his vitals. Seems like we have a long afternoon coming.
No doubt.
Let's take a moment to review what went well in this scenario. Did you notice the MA greeted the patient this time and found out why he was there? And although the physician still didn't tell him about the patient, he did get the information from the receptionist. And you probably noticed the communication was much more respectful, and clearly there was less frustration in the tone. Now let's talk about the importance of good leadership. Traditional definitions of leadership center on the concept of influence. Leaders influence team effectiveness by facilitating team actions and ensuring that teams have the necessary resources for optimal performance. They also ensure that roles and tasks are understood by all team members. and being knowledgeable of the team member's skills and expertise in order to properly allocate tasks and material resources. High-performing team leaders ensure teams engage in 3 critical events: to plan, problem solve, and improve over time. Briefs are held for planning purposes. Huddles are used for problem solving, and debriefs are used for reflection and process improvement. We'll explore each of these in greater detail. As we go forward, keep in mind that although the team leader typically facilitates team events, any team member can request a brief, huddle, or debrief at any time as the need arises. This approach is an example of shared leadership. Let's take a look at a video and you determine whether these are desired leadership skills.
James and Schwartz, how may I help you? All right, feel better, Caroline. I'll pass it on. Excuse me, Dr. James?
Yes, Emily, what is it?
Carolyn just called in sick, and she's the triage nurse today.
Look, Emily, I don't have time for this today. Just call one of the nurses up to the front desk if you see a patient that needs immediate care. They'll take it from there.
But Dr. James, none of the other nurses scheduled today have any triage experience.
Emily, just call a nurse. Thank you.
Excuse me, Dr. James.
Yes, Sam, what is it?
Emily mentioned we have no triage nurse today, correct?
Yeah, that's correct. She'll call for one of you from the front desk if she sees a patient that needs immediate care.
All right, should we do a huddle or brief or something to explain what's going on to the rest of the staff?
No, that's okay. You just tell everybody, okay? Thanks, Sam.
Sure, okay, I'll try and tell everybody.
Sam, before anything else, can you quickly check to make sure that exam rooms 1 and 4 are ready? We're expecting an onslaught of flu patients today, and we have 3 appointments first thing.
Yeah, sure, I'll be right there. Yeah, we need to see you right away.
Miss Rainey, if you'll just have a seat in the waiting room.
We'll be with you in just a few minutes. Please have a seat in the waiting room.
All right, thank you. If you'll just wait a few minutes in the waiting room.
Thank you.
Emily, why are you calling a nurse up here to see almost every patient that comes in?
The triage nurse called in sick this morning. All the patients keep telling me that they're very sick. So I'm calling you guys to make sure they don't need immediate care.
Wow, okay. I really wish someone had shared that information with the rest of us.
I'm sorry, Kara. I told Dr. James.
It's not your fault. Just keep doing what you can, Emily, and we'll all try to come up and help you when we get a free moment.
Thanks.
Was this physician an effective team leader? Let's discuss the effectiveness of the leadership in this scenario. Clearly, this physician was the leader. However, he didn't put together a plan for the team when a situation arose. The team was unaware that the triage nurse had called in sick, and the receptionist can't do a medical assessment on a patient, so she had to call an appropriate staff member to assess every patient. The staff just seemed to be trying to get through the day in a very chaotic, uncoordinated way. Briefs and huddles are 2 of my favorite communication techniques for getting everybody on board with a plan. They're easy to teach and do. Briefs and huddles are sometimes used interchangeably. However, briefs are usually held at the beginning of the day to plan for the events of that day. A huddle is a quick, reactive, touch-based meeting tool to help team members regain situational awareness. Briefs enable a team to anticipate care needs and special situations so that members of the care team can support each other through the day. In addition to care, team briefs, all staff briefs, can be used to alert everyone to staffing issues or upcoming events or important policy updates. And there isn't any one right way to conduct a good quality brief. Briefs can range from a few minutes to 20 minutes. They may be held daily or at the beginning of each clinic session, and the agenda varies depending on the team needs. The goal is for a brief to be an effective and efficient tool for communicating about patients and the flow of the patient's office visits. The most effective briefs involve some preparation in advance. For example, in some practices, a medical assistant scrubs the charts or does pre-visit prep work in advance, identifying preventative care gaps, chronic disease management needs, screening alerts, or patients with recent hospitalizations. In your practices, you'll want to ensure that patients have had all their tests completed and results have been reviewed by the physician before they have a surgical procedure. Briefs often result in great improvements for a relatively small time investment. Practices often report that staff are more likely to show up on time and communication is quickly improved. The use of a brief checklist is invaluable for ensuring that items are covered in a standardized and systematic fashion. The following information should be discussed in a brief and therefore should be on your briefing checklist. First are the team membership and roles. Who's on the team and who is the designated team leader? What is the clinical status of the team's patients, the current condition, diagnosis, plan, and status of each patient assigned to the team? Also, the team goals, the pitfalls and barriers, what's to be accomplished and who is to do it? And any issues that are affecting team operations, such as resources that are normally available that may be restricted during that particular day. Successful teams measure their effectiveness in terms of goal achievement, and performance goals typically are set during that team brief. With the team leader facilitating the process, team members actively participate to establish both clinical and teamwork goals. The huddle quickly allows team members to discuss critical issues and emerging events, to also anticipate outcomes and likely contingencies, and to assign resources and express concerns. It's a tool for developing shared understanding between team members regarding the plan of care. Because information changes over time, the huddle is an important tool for monitoring and updating the team. A sudden increase in the activity level of an individual or the team signals the need to reevaluate workload status, and workload distribution may need to be adjusted. Can you think of some recent examples in your own practice where a huddle would have helped your staff? So in the poll, everyone said that they aren't doing a debrief. So I'm going to discuss the debrief and how important it is to your practice. The debrief is a short, informal information exchange used as a process improvement tool. It occurs after an event or workday and is designed to improve teamwork skills. Debriefs are most effective when they're conducted in an environment where all actions are viewed as learning opportunities. I find that the debriefs are often neglected, even in the hospital practice, yet it's critical for learning from mistakes and improving processes. Debriefs should include an accurate recounting and documentation of key events, an analysis of what occurred, what worked, and what did not work, a reflection on why and the implications for the practice. Also, a discussion of lessons learned and how the team will alter the plan for next time. An establishment of a method to formally change the existing plan to incorporate those lessons learned. Also, most importantly, a recognition of good team contributions and catches. Documentation of the debrief is critical, as this information is used to change a process and document quality improvement activities. Now let's take a look at how a debrief should be performed.
James and Schwartz, how may I help you? All right, feel better, Carolyn. I'll pass it on. Excuse me, Dr. James?
Yes, what is it, Emily?
Carolyn just called in sick, and she's the triage nurse today.
Okay, do me a favor. Gather up the staff. We will need to do a quick huddle at the front desk before the day begins.
Got it, right away.
Okay, perfect. I'll be there in 10.
Okay.
We're swamped today. It's flu season. We don't have time to stand around.
I know, but Dr. James called this huddle. He should be here any minute.
Good morning, everyone. I need to tell you that Carolyn called in sick and she was assigned to triage. So we have 3 providers here today, so we'll take turns covering for Carolyn. During your triage shift, you'll see your scheduled patients every 30 minutes instead of every 15. Any patient you can't see will be passed off to another provider during your triage shift. That way we can ensure that anyone who needs immediate care is appropriately seen. Any questions? No? Okay. Be sure, everyone, to explain to our patients that the wait may be a little longer today, but we're doing the best we can, all right? Thanks, everyone. Let's have a productive day. All right, sir. If you'll just have a seat right over there, we will get to you as soon as we can, all right? Thank you.
We're going to see you right away, so why don't you come on back in? It's that first floor there on the right.
All right, sir. We'll get with you as soon as we can, okay? You can have a seat back in the waiting room for us. Thank you.
Excuse me, everyone. Can we have a quick debrief about today's events? Kelly, Sam, is that everyone? Yeah. All right, good. So, what do we think about how we handled our workflow today without a triage nurse?
I'll start. When I first heard the news this morning, I was a bit wary, but from the moment you called the huddle, I felt fine.
It was busy, and everyone was alert and acted as a unit. We seemed to communicate well and pulled it off just fine. I'd say it worked for us.
I'd agree with Dr. Schwartz. I mean, although this isn't something that I'd commit to on a daily basis, I think it would work as a last resort. I mean, we managed to come together as a team and support each other, and that led to a successful day.
I think it went well. Thanks for great leadership today, Dr. James. It helped us all ease into the situation confidently. Everyone appeared to be aware of what was happening and adjusted to make sure the patient's needs were met.
Don't forget Emily. She followed up with Dr. James immediately.
Thanks, Kelly. So if a triage nurse does call in sick again, should this be the plan of action?
That's a good question. From everything I've gathered today, this does seem to be a completely viable solution. So if everybody is comfortable with it, I think we should adopt this as the new default. Everybody on board?
I might just suggest that we have a provider or a triage nurse on call for this situation specifically. I feel that our patients shouldn't be passed around unless completely necessary.
Point taken, Miles. I'll look at the schedule, see what we can do about getting somebody on call. Anything else? All right. Well, excellent work today, folks. Let's close this place down and go home, all right? All right.
I hope you'll all agree that this was an effective debrief in that everyone had input and they were able to establish a protocol should this situation ever occur again. In summary, the Team Steps teamwork skills can help you facilitate teamwork in your practice, which in turn will result in a safer practice for your patients and a more rewarding working environment for staff. Each Team Steps teamwork skill facilitates teamwork, is dependent upon or moderated by other skills, and contributes to team performance, quality of care, and patient safety. You may be thinking, how can I demonstrate the need for Team Steps in my own practice? As an office or risk manager, you may want to take a look at actual and/or potential adverse events that may have happened in your practice and ask yourself, was there a lapse of communication? Perhaps no one stopped the line when there was a safety problem. Maybe staff did not have a shared mental model or situational awareness. Possibly staff were afraid to speak up to a higher authority. Identify what TeamSTEP's tools may have thwarted these issues from ever arising and implement those tools first. There are 3 versions of the TeamSTEPs course. The classroom section has all the PowerPoint slides and videos as well as handouts. All of the materials are free to download and will provide everything you need to implement TeamSTEPs in your practice. Here's the link for the office-based TeamSTEPs program, as well as the link for the Culture of Safety survey. The Culture of Safety survey should be done prior to training, and then about 12 months or so after you have fully implemented the TeamSTEPs program in your practice to see if safety culture attitudes have changed. Let's move on to informed consent, where we discuss how effective communication can create a meaningful informed consent discussion. Please just take a moment to answer this question. Does your practice use a comprehensive informed consent refusal process for procedures, tests, and referrals that you recommend?
All right, Kelly, I have launched the poll and results are coming in. I'm just going to give everyone a little bit more time to enter their thoughts on this. Okay, I'm going to go ahead. I'm going to close the poll, and here are the results.
Great. Well, wonderful. We have 63% of you are using both informed consent and informed refusal. That's wonderful. 38% of you are using only informed consent. If you would like an informed refusal sample form, NORCAL has one that you can take a look at and modify for your practice. And 0% of you don't have a process at all, so that's great. When physicians and patients communicate, they exchange information so that the physician understands the patient's symptoms or problems, and the patient in turn is told what the cause of the trouble might be and what can be done to further investigate or treat the condition. To initiate the treatment process, the physician must have the patient's consent. That is, the patient must voluntarily agree to cooperate with the physician's plan. There is a difference, though, between general consent for treatment and informed consent. When a patient presents for an appointment with a physician, the patient implies consent by appearing for the appointment and undergoing an examination. When in the office, a doctor says to the patient, "I want to take your blood pressure," and the patient rolls up his sleeve to accommodate the cuff, this is an example of general consent. For a variety of reasons, however, many forms of treatment, including surgical or invasive procedures, require the patient's informed consent. To satisfy the requirement that a patient's consent is informed depends in part on state law. That is, that some states require specific informed consents for certain procedures, and in part on what a reasonable person would need to know in order to make a decision. Generally, the physician is responsible for ensuring that the patient has been given an explanation of the proposed procedure or treatment and its risks and benefits, has also had a chance to ask and get answers to those questions, and has then agreed to the proposed procedure. Some things you'll want to consider when having an informed consent discussion with your patients are the health literacy of your patients. The AMA has a health literacy video that can be found on the AMA Foundation's YouTube channel, and it's excellent. I would highly recommend taking a moment to view it. The CDC now has everyday words for public health communication. Who does the informed refusal, and how is that documented? If a patient is refusing a procedure that is necessary for their health and well-being, it's important to verbalize and document this discussion carefully. It's very important that the patient understands how refusing this procedure could negatively impact their condition. Also, most often we see informed consent as a secondary allegation when the patient has an adverse outcome due to a procedure. Most often we hear patients saying, "The doctor never told me that." I'm going to give you a couple of case examples and then we'll discuss the risk management recommendations. First, we have a 26-year-old female who presents to a plastic surgery practice for a rhinoplasty consultation. She showed the surgeon a picture of a popular celebrity and stated she wanted a nose just like the celebrities. The surgeon guaranteed that she could give her the exact same nose as the celebrities. She further stated that complications for this procedure are rare and told the patient that she should heal rapidly with very little downtime. The informed consent discussion consisted of all the benefits and little to no discussion of risks or alternatives. After this discussion, the patient was excited to go forward with the procedure. During the procedure, the surgeon determined that she could not take enough bone given the structure of the patient's nose to give the patient her desired look. The patient was unhappy with the result and sued the physician, claiming that the physician guaranteed she could give the patient the same nose as the one in the picture she showed to the physician. The patient further claimed that her nose looked worse than it did before the procedure and that the surgeon ruined any chance of a revision to improve it. Here we have another case example also involving a cosmetic surgery procedure, but the principles of the informed consent process apply to any care setting where aesthetic medical services are done that have the risks, the benefits, and the alternatives offered. In this case, we have a 56-year-old male who presented to a cosmetic surgeon's practice for a facelift consultation. The surgeon took a medical history from the patient and found that he was a heavy smoker. He advised the patient that he needed to stop smoking before the surgery. 2 months later, the surgery was scheduled and performed without verifying that the patient had stopped smoking. 10 days post-op, the incision sites did not seem to be healing. 3 weeks later, the skin at the incision site started sloughing and signs of infection were present. When asked if he quit smoking, the patient stated he had not. He stated he didn't know why he had to stop smoking and everyone was always telling him to stop smoking, so he didn't take it seriously when the surgeon told him to stop. The patient sued the surgeon for improper technique and failure to warn him about the impact smoking would have on the healing process. I'll review some of the risk management recommendations for the consent process, and I want to stress that this is a process. It's important to develop an informed consent process, including 4 essential elements: the discussion, the education, the documentation, and the form. You want to discuss the risks, benefits, and alternatives. Include risks that may be unique to the patient due to previous medical history and comorbidities. For example, delayed healing due to diabetes. Also explain to patients why they need to stop smoking or stop taking certain medications or supplements. Don't assume that they'll stop without knowing why. And do not guarantee results. Be transparent about the risks and downtime required to heal. And provide educational materials that might help the patient better understand the proposed procedure. And document any educational materials that are used. Also document any relevant specifics of the discussion. Include questions the patient asked and how you answered them. And you do not want to delegate the informed consent discussion. Confirmation that the discussion has taken place and witnessing the signing of the form can be delegated, but the practitioner performing the procedure or the treatment is responsible for the informed consent discussion with the patient. So in conclusion, checklists are safety tools that enhance team communication and support a culture of safety where all levels of the healthcare team are encouraged to speak up when there is the potential for something to go wrong. And implementing team steps training can help improve team communication through the use of various evidence-based communication strategies. Also, a thorough informed consent process ensures that your patients have an understanding of the risks associated with the procedure or prescribed treatment and can help to mitigate your risk to lawsuits when a patient is not happy with the outcome of a procedure. Implementing process improvement in these 3 key areas helps to mitigate your professional liability risk and enhances patient safety overall.